Good afternoon, good morning, pardon me, ladies and gentlemen, and thank you for the kind introduction. Let me have a look here. Do you see the cursor? Yeah, I think you do. So my talk is about the development by our company of synthetic human relaxin-2, that is a relaxin that is synthesized to be identical to your endogenous native relaxin-2 for chronic cardiovascular indications, especially for heart failure with preserved ejection fraction. So why HFpEF? I think you know that that heart failure is a real socioeconomic problem. So 50% and rising of patients with chronic heart failure have heart failure with preserved ejection fraction. So I'm talking approximately 7 million people in the EU and US, at least 6.5 million in urban China. And it's safe to say that in the Middle East, in India, in Southeast Asia, this lifestyle diabetes HFpEF pandemic is on the rise. And in general, chronic heart failure is the most common cause of hospital admission. And it's usually among the top 3 most common causes of death in industrialized developed countries. And the prognosis of HFpEF, heart failure with preserved ejection fraction, is really comparable to that of heart failure with reduced ejection fraction. So it's grim. It's 50% dying over 5 years. So meanwhile, it's deadlier than most cancers. One has to emphasize this. However, in striking contrast for HFpEF, in contrast to HFrEF, there is no mortality-lowering pharmacological treatment today available, despite some recent advances which at least lowered hospitalization for heart failure. So SGLT2 inhibitors and finerenone aminoglycorticoid antagonist. To me, HFpEF has always been the job description for relaxin-2, and I'm trying to tell you why. I like this sketch here by, wait, I will check if I can, yeah. Okay, the laser pointer is better. I really like this sketch by Paulus and Schöpe of 2013. It shows you the pathophysiology of HFpEF. You know, HFpEF actually is a whole body metabolic inflammation, which then causes a stiffening of the vessels. We call it endothelial dysfunction, and a stiffening of the heart. We call it diastolic dysfunction. So actually, heart and vessels fall victim to an inflamed whole body condition. And actually, almost every aspect of this syndrome is addressed by relaxin-2. And I give you some examples. This whole body inflammation is driven by the usual suspects. It's age, of course. It's age, and it's all the comorbidities of aging, overweight, diabetes, hypertension, smoking, you name it, the usual suspects. So, and relaxin-2 in green is a vasodilator. It inhibits at different levels. I come to that later. Endothelin-1, one of the most potent pro-fibrotic agents and vasoconstrictors. We have patents. It's anti-diabetic. It's a strong anti-inflammatory drug. It also acts via the glucocorticoid receptor. More to it in a minute. It's a strong antioxidant. It inhibits vascular inflammation. It's one of the strongest antifibrotic agents we know, and it's a strong antiarrhythmic. It's preventive against myocardial hypertrophy. It promotes endothelial dysfunction, so prevents vessel stiffening, functional vessel stiffening, and a little bit hidden below this bar here, it really reverts diastolic dysfunction by regulating the diminished phosphorylation of the sarcomeric proteins and by restoring the diminished nitric oxide protein kinase G axis. So relaxin-2, actually, it is from the insulin superfamily, but it's a realm of its own. A nice story is this was discovered as a pregnancy hormone, and in human pregnancy, it's the hormone that in the first trimester is the master switch for the adaptation of maternal circulation to the needs of the pregnancy. And You could say in a philosophical way, actually, we are using many of these actions now to rejuvenate the aged heart. So I think that's a good story. And when I say relaxin, I usually mean relaxin-2. That's our drug. Relaxin-3 is a neurohormone, and the presence of relaxin-1 in humans as a peptide is obscure. So when I say relaxin, I mean relaxin-2. There's a cognate receptor, relaxin family, peptide receptor 1. It's a G protein coupled receptor. And this is a very personal history. I'm doing relaxin research for 25 years now. I can really say we have brought it into cardiology. We discovered that endogenous relaxin goes up with the severity of heart failure. And we discovered a lot of compensatory protective actions. And this is how this idea came into being, relaxin be used for heart failure. We did a lot of mechanistic research, for instance, endothelin type B receptor mechanism of vasodilation, the mechanism how relaxin, apart from its own receptor, activates the glucocorticoid receptor. We did the first clinical study in stable HFrEF patients. You would call it a phase 1B nowadays. And this was the basis for Novartis' acute heart failure program in the early 2000s. And we did a lot of work on pharmacology. So what is so special about this hormone? It's super complex receptor signaling and pleiotropic signaling. So the receptor RXFP1, depicted here, it's a G protein coupled receptor in its own class because it's so complicated. So native relaxin has to bind to the linker here, to the leucine-rich repeat domain here, to parts of the transmembrane domain. Each step causes a subtle conformation change, and eventually this allows this green tail here, the so-called LDLA module, to tether to the transmembrane domain and switch on signaling. And this explains to you why so far there is no non-peptidergic compounds, despite high throughput screenings by Big Pharma, that is a real full agonist at this receptor. There is some what we call biased agonists. They bind the receptor, but they are not doing the very same as native relaxin, and they bind it at different sites. Next point, there is no such thing as canonical signaling. You know one cell and you know everything. No, you have to check it out for every cell type and maybe for every different condition. Major pathways, though not present maybe in every single cell, are the CAMP protein kinase A pathway, the nitric oxide protein kinase G pathway, different levels of inhibition of endothelin-1, so gene expression, increase of its clearance receptor, endothelin type B receptor. Then it's a real agonist at the glucocorticoid receptor, a most strange thing. What we have meanwhile NMR data on it, it can really displace glucocorticoids, dexamethasone, prednisolone from the GR. And the affinity is identical. The good thing is it does not come with the notorious side effects of glucocorticoids. So there is no such thing with relaxin like steroid diabetes, like disturbance of wound healing, like GR receptor downregulation upon chronic use. So it's really a kind of a modern glucocorticoid receptor agonist. There is interaction with the angiotensin type 2 receptor, and there is a Wnt pathway. I come to this in a minute, which really leads to what you could call myocardial rejuvenation. The basics, it's, of course, one part is it's a vasodilator acting at different time levels. In the acute setting, it's an eNOS activator. It also activates the other NOSes or increases their expression. In some vascular beds, it uses prostanoids, prostacyclin, for instance. If you go in the middle term time frame, so hours, it upregulates endothelin type B receptors, which are vasodilatory, and this involves different matrix metalloproteinases and even VEGF. And in the chronic phase, it also leads to a vascular remodeling, which just promotes flow. And this is one of the first investigations in humans, human systemic arteries, pre-contracted. And this is substance P, is a very strong positive control. And in here is relaxin, and it's an endothelium-dependent vasodilator. And we could confirm this vasodilatory cardiac afterload decreasing effect of relaxin in this first phase 1b study a couple of years ago. This was in the ICU setting, hemodynamic monitoring, 24 hours of relaxin infusion. We did a huge dose escalation. It was very safe. And you see this marked increase in cardiac index, no difference in heart rate, meaning it's really an increase in stroke volume. That's what you want as a cardiologist. And it's protective of endothelial dysfunction, which I told you is a hallmark of HFpEF. This is a red aortic ring model. You treat red aortic rings by different doses of tumor necrosis factor, low dose, high dose. And you see that this actually beautiful vasodilation upon acetylcholine is heavily impaired dose-dependently by TNF. And in between, you see co-incubation of TNF with increasing dosages of relaxin, and they really revert this endothelial dysfunction. And this, and I cut a very long story short, rests actually on 4 pillars, you could say. The first one is you prevent via GR, the glucocorticoid receptor, you prevent the arginase upregulation, which deprives nitric oxide from its substrate, arginine, and leads to superoxide production of enos. Then you downregulate the constrictor endothelin-1. You kind of work on the enos dysphosphorylation and downregulation, and you induce, at least in this model, superoxide dismutase, and this prevents part of the oxidative stress in this model. Some work on the glucocorticoid receptor. Just a good picture. This is HeLa cells, that's endothelial human cells. And the upper row here is just the resting state. You see nuclear staining, you see glucocorticoid receptor in the cytoplasm, you see some endogenous relaxin synthesis of those cells, and you see the overlays. And then you challenge those cells with exogenous relaxin, be it fluorescence labeled or you use antibodies thereafter. And what you see is both the GR and relaxin travel into the nucleus. And in fact, we know it really binds the GR and travels piggyback into the nucleus and then exerts all sorts of GR related effects. And I hope you can see it. It's hidden by this bar. For insulin, so a peptide from the superfamily, there is no such effect. You see the GR remains in the cytoplasm. So why is that important for heart failure? For instance, this is part of its organ protective actions. That's from a mouse model of liver transplantation. That's primary hepatocytes, mouse hepatocytes. You can challenge them with hydrogen peroxide and up go the transaminases here. And you can almost totally revert this by relaxin. But if you knock down the GR, all this is gone. So in this model, in this whole in vivo transplantation model, the relaxin effect totally depends on the glucocorticoid receptor. And another example, I told you HFpEF is whole body inflammation, and this is THP macrophages, so human macrophages. You challenge them with endotoxin, up goes TNF-alpha. That's a very common model. Different timelines here. You can block this by relaxin or by dexamethasone, a classic steroid. And if you have a GR antagonist, and this is mifepristone, you know it from abortion, a GR and progesterone antagonist, you block these effects. So very important parameters for heart failure here. And then I mentioned Wnt. If you know Wnt, you may know it from embryology, so from organ development, or the inhibition of Wnt pathways from osteoporosis. That's how Dickkopf acts, a Wnt antagonist, which causes osteoporosis. So a couple of years ago, no one would have believed that a Wnt pathway is active in adult myocardium, but it is, in fact. And relaxin increases Wnt expression in some cells. In others, it just decreases the Wnt inhibitor, Dickkopf. And there's some input from this pathway, that's the glycogen synthase kinase 3 beta, which exerts a tonic inhibition here, and this is then inhibited by relaxin. So no matter which way, the final pathway is increase in this signaling here. Beta-catenin is the transcription factor, and this transcription factor is fully responsible for the electrical remodeling through relaxin, and I will show you data on that. It's partly responsible for antifibrosis and anti-inflammation exerted by relaxin. And this is a study done by partners of ours at the University of Pittsburgh. It's the Fisher 344H rat, an established HFpEF and aging model. It's rats, male, female, 9 young rats versus 24-month-old rats. And altogether, you see especially pronouncedly in the females that aging is about fibrosis, and it's about inflammation, and sometimes it's about oxidative stress. And all pathways are inhibited by relaxin. And that is why I really call it a rejuvenation. Now, the field sparked some interest. And while we are using native relaxin, we are synthesizing it. There is also relaxin analogs out in the field. But what I would like to emphasize is there is a difference. So when I say relaxin analogs, that is either those non-peptidergic small molecules that are biased agonists that do bind differently to the relaxin receptor and do not ignite the whole signaling, or it's sequence-modified single-chain relaxin coupled to antibody fragments just to increase half-life. While this is really meticulous engineering, it comes at a price, and most likely you lose significant pathways. And I have shown you that the GR and the Wnt pathways are really of the essence here. And I bring you some examples now how modified relaxins are no longer capable of igniting those pathways. Look, this is rat isolated cardiomyocytes, aged rat cardiomyocytes. And in those cardiomyocytes, the fast sodium channel is downregulated. And this is part of the underlying mechanism for atrial fibrillation and ventricular tachycardia in those cells. And a medium dosage of relaxin upregulates this channel hugely, but there is no such effect by B7. That's a sequence-modified truncated single-chain relaxin. That's up to 100 nanomolar, the 4-fold level. And I told you about the glucocorticoid receptor. That's just another example. This is ML290. That's the lead substance for non-peptidergic small compounds, for the so-called biased agonists. They bind the receptor, they do something, but they don't do everything that is done by relaxin. And that's an example for it. That is mycopatocytes. We know that relaxin upregulates the glucocorticoid receptor here. Even relaxin that does not bound its own G protein coupled receptor upregulates it because it uses the GR, but there is no such thing done by ML290. So again, those two pathways we think are really of the essence when it comes to chronic treatment of HFpEF. Now I will jump into some animal data and HFpEF models. Actually, HFpEF in the clinical setting is kind of an overlap between aging, we use the aged rat here as a model, between a lot of cardiometabolic changes, such as obesity, diabetes, insulin resistance, lipotoxicity, stuff like this. And that's the ZSF obese high-fat diet rat as a model. And of course, hypertension-related pathways, for instance, the angiotensin-2 model. And I give you some data for every phenotype. That's the angiotensin-2 model. This is work done by a different group. This is published. They infuse quite a high dose of angiotensin. This increases, of course, blood pressure in rats. And this leads to end organ damage. You can see here albuminuria in the kidneys here, and you can see glomerular sclerosis in the glomeruli. And if you switch on relaxin 1 week later and then co-infuse relaxin angiotensin-2, down goes the blood pressure and down goes actually to normal the end organ damage. That's a very simple approach for this angiotensin or hypertension phenotype of HFpEF. Then I was talking about the aged rat. And the aged rat is prone to all sorts of arrhythmia. And in this paper, it is about atrial fibrillation. The fast sodium channel is down in those cardiomyocytes. And after 2 weeks of relaxin therapy, it goes up. It's a huge increase in the current here. And in parallel, you are reducing atrial fibrosis here. That's collagen, different collagen types. And this mixture of less fibrosis and higher conduction velocity, we think minimizes re-entry mechanisms for different sorts of arrhythmia. And if you then go and try to induce atrial fibrillation in those hearts by different pacing protocols, what you see is in rat, that's the vehicle-treated rats, there is often you can induce sustained atrial fibrillation, but you cannot induce sustained fibrillation or ventricular tachycardia in relaxin-treated animals. And this is our main model. I think it's actually the most established rodent model in HFpEF. It's the ZSF obese rat. It's a rat with 2 different leptin receptor mutations. And if you feed them a high-fat diet, they over weeks really develop clinically important HFpEF. You really monitor them by echo, sometimes over 10 to 12 weeks. It's variable how fast the model develops. That's the sad thing about it. And then you define a threshold. When you think by echo, they are in HFpEF, and then you treat them for 2 weeks. And then you, after sacrifice of the animals, you do Langenhoff hearts for arrhythmia induction, and then you do immunofluorescence and or related parameters. And this is just to show you that it is really a HFpEF model. So with time, 10 weeks, that's the young age, to 18 weeks, the ejection fraction is preserved, but the myocardial relaxation velocity is markedly decreased. It's just the absolute amount here. And up goes E to E prime. That's what we use in the clinical setting, in the eco lab, just that the normal values are different from human values, but the trend is the very same here. And you have a significant atrial enlargement. So that's like in the human setting. And at first, as a proof of concept, we infused relaxin continuously by Alset mini pumps, so at a very high maximum dose for 2 weeks. And what you can see is after initiation of treatment here, week 20, and look at the green columns, that's relaxin, that's verum. We normalize the endothelial dysfunction down to young age levels, and we normalize left atrial enlargement down to young age levels. within the course of disease, there's an increase in natriuretic peptides, almost 5-fold above controls, and this is almost normalized here. And this goes along with anti-fibrosis and electrical re-remodeling. As I said, this is related to the Wnt pathway. The Wnt pathway is upregulated in the relaxin animals. That's Wnt, that's beta-catenin. That is the downregulation of collagen expression, which is partly related to Wnt. And then fully Wnt dependent is the upregulation of the fast sodium channel and the upregulation of the initially depressed connexin 43, which is a tight junction protein. So increase conduction velocity. Now you could say we are in a dilemma. I tell you, do not tamper with a peptide because you're losing signaling. But on the other hand, if you look it up, the half-life of relaxin in circulation is below 1 hour. So what is to do? And here is our solution to it. This is published, and this is left ventricular tissue sections of rats. And those rats were treated with a daily shot of sub-Q relaxin, native relaxin, synthesized native relaxin, for 2 weeks. And then 24 hours after the last shot, animals were sacrificed, and we probed the slides with a relaxin app. And you see at the target tissue, there is still relaxin. This is a down titration with the exogenous relaxin just to prove specificity. So that means a relaxin bolus, a sub-Q bolus, is gone from circulation after 8 to 10 hours. We have PK data on that. That's just established, but it lingers on in the tissues where you want to have it. And that's the nice story about it. So why is that? It's receptor pharmacology. This receptor, this RXFP1, is neither internalized nor desensitized like so many other receptors. And once relaxin has bound to this receptor, it just sticks there. It's a very slow off rate. And then I was telling you about many genomic effects, and actually it comes down to pushing the swing at just the right time. So this is our concept, and this is the concept we are also using for early clinical development. And now this is hidden behind the Zoom bar, and this is daily bolus of synthesized native relaxin in this HFpEF model, and the results are absolutely identical to those obtained upon sub-Q infusion. Even with a lower dose, it's 100 micrograms per kilogram here. This is females. You see the diastolic dysfunction is brought back to normal as compared to young age levels, and left atrial enlargement is stopped. It continues with vehicle, and the very same holds good of males. The only thing maybe is that left atrial enlargement is even more pronounced in the natural course of disease in males, but otherwise it's almost identical. And now a little bit more on arrhythmia. When it comes to the clinical setting and to the recent phase 3 studies in HFpEF, the most important single cause of cardiovascular death, arrhythmia, sudden cardiac death in the HFpEF, in the large HFpEF trials. And that's why I think this at least makes us optimistic why we could really tackle mortality in HFpEF. Because in the different models, in the aged rat, in the ZSF1 rat, and even in rat models of pulmonary hypertension, and we are extending this to a pig model now, we can really suppress atrial and ventricular arrhythmia. And this is examples in the ZSF1 rat. You explant, so to say, the heart. You use a Langendorf model, and then you try to induce, in this case, atrial fibrillation. That's the vehicle group, and you can induce sustained atrial fibrillation. And this is the relaxin group. You decrease the stimulation interval until there's loss of capture, you cannot induce atrial fibrillation. And the same holds true for the ventricular tachycardias. And this is, you see, regarding AFib, it's no sustained AFib after relaxin, but 60 to 80% of vehicle rats develop a sustained AFib. And the same holds true for incessant ventricular tachycardia. There is more to come, but it's too early to talk about this today. But I would like to announce it because it lends support for our clinical program. We have set up an ongoing program using biopsies taken from left and right ventricles of both female and male HFpEF patients, and I can say you. It looks like very, very corroborating, brilliant data. And this leads me to my summary. To me, HFpEF is still the unmet medical need in contemporary cardiology. And I would say relaxin's unique receptor and signaling characteristics render it an exceptionally stronger candidate. So we have a multifaceted syndrome like HFpEF, and this needs a pleiotropic approach. At the preclinical level, the relaxin-2 concept is effective in all three phenogroups of HFpEF models. Relaxin delivery reverses diastolic dysfunction, arrhythmia susceptibility, inflammation, as well as excess fibrosis, and rejuvenates aged myocardium. The atrial and ventricular antiarrhythmic properties of relaxin-2 are clinically important for mortality reduction. In the clinical setting, AFib heralds worsening of HFpEF, and sudden cardiac death poses the most frequent cause of cardiovascular death. And with this bolus therapy, that is how we call it, signaling can be achieved with periodic pulses of the peptide, irrespective of its short half-life in circulation. And this enables excellent therapy control, very important for notoriously blood pressure labile patients, and good compliance in highly susceptible patients. And the entire signaling portfolio of the native peptide, and I was talking about Wnt and the GR, is of the essence here. And this pleiotropic signaling is most likely trimmed down in relaxin analogs by relaxin modification. And Source HF, a phase 2 clinical trial in HFpEF, is underway and will start in early 2026. I have to thank a lot of people from the bottom of my heart. This is first the group of Professor Salama at the Heart and Vascular Institute in Pittsburgh. It's Ross Bathgate they are doing here the animal models. Ross Bathgate in Melbourne is doing the basic research for us. Immune Diagnostic helps out with the diagnostic stuff. This is Paul Gooley is the professor that does the NMR studies, the GR. Nazar Hamdani, a very established researcher for basic research in HFpEF, is doing the HFpEF biopsy program for us. I have to thank my colleagues in Paris, in Porto, and our consultants. I thank you for your attention. I'm happy to take your questions. Thank you.